This topic is digital impression in implant dentistry. Please begin the presentation.
Okay, thank you, Chairman, Dr. Kim, and Dr. Wang. And good afternoon, everybody. And I have to appreciate the people who organized this short presentation because I was last minute. I asked them to put my name in last minute. Okay, I also know that I have very limited time for this presentation, and my topic today is the digital impression in implant dentistry. And maybe some of you are interested in digital impression and know about it. It's a digital impression form in Switzerland, jury by Professor Morgan and Brian Destiny, and they call COEXeso. And after 1980, they started to treat the patient. In 1985, they saw the first patient, and they developed more and more, and now we come up with the blue cam. Not only the COEX, many companies are interested to make digital impression units, and Cadence come up with the ITERO 2006, and Lava also has the 3M Lava COS, and the D4D has D4D Dentist. So Dr. Kakilia is interested to compare this digital impression units. So he made some classification, and he divided two groups. And first group is just the acquiring data system, and second group is the acquiring data and the manufacturing at the same time. So these two groups are different with the other. And I don't think I have too much time to explain all four, so I'm going to focus on ITERO, which I'm going to present it now. So the main advantage of ITERO is that it's only taking the data, but also it can work with any other system, means open architecture. So when you have an STL data which you can design the restoration of the virtual model, you can work with any other CAD/CAM units. So that's a big advantage. And the way you're using is to put the prescription, it decides how to take the pictures and the procedure of taking pictures, taking scans. And you can have a scanner, and exactly machine tells you which tooth you want to take and which angle you want to take. And then you can get the virtual model. So, and then send the click, then the data will send to the center, they modify it to the STL, and you can use the data itself, and also you can fabricate the model from the data, and you can work with the conventional lab work. Then you can try in patient's mouth and cement. So it's very simple. But the problem is, it just come up here in the market 2006. We don't have that much evidence. So my first question was, how exactly, how was it fit the restorations from the digital scan? So that was my question, and I asked one of professor in Korea, and we had a clinical study. We started a clinical study. There's a single crown case in natural tooth. After trauma, I did root canal treatment and prepped, and I made impression. At the same time, I scanned it intraoral scan. So I made two zirconia copy, one from the CAD/CAM data, one from the conventional stone model. Then I tried it in patient mouth, and I made a replica, which is the layer of feature curve and the polyvinyl xyloxime injected mold. This is the end of the single tooth, and the other single crown with the metal porcelain core, which may affect the result because of the metal reflection during the intraoral scan. So I had the same thing. I made the conventional impression with the polyvinyl xyloxime, and also I scanned it, and I made a model, but I used the data to fabricate this copy. Then I did the same thing. And this is multiple crown case, and multiple anterior crown was splinted and had periapical lesions. I found the periapical lesions, so I have finished the root canal treatment. Then I made impression, and I scanned at the same time. So I made four individual copings, exactly 8 individual copings, and I tried it in patient mouth, and I made a replica. This is the end of the treatment. And another patient needed a lot of crowns, and I had these posteriors to prep and made impression and scan at the same time, and I tried 4 copings in patient mouth and the posteriors as well. So after all this, we cut the replica mold with a laser blade and examined the microscope. So we measured the thickness by not by the human, by the program. Software detect the thickness of the fit checker and check the fit. So especially I just check the margin. So we come up with this clinical study. Within the limitation of this study, the results suggest that no significant differences were found regarding marginal fit of zirconia cores between digital scanning time and conventional impression time. All the copings were fine, and the digital impression is compatible enough to make just a conventional type rubber impression. So how about digital impression implant? We're familiar with this system, the ICOI system, with a two-piece notch abutment, healing abutment, so you don't need to change the impression coping to make impression. And with the CAD-CAM, making abutment and the final restoration at the same time. How about the digital impression, like a CEREC? You can still have abutment level impression, like a natural tooth. So ICOI is the only few system that you can make an implant level impression with a digital scan. They call iFit. First time I tried it on the model. This is how it looks like. We call scan body instead of scan coping. With the hex, you can engage to the hex on the implant. With the notch, you can just duplicate the data and this rear scan. So this is notch, and this is how it looks like after connected. And I scanned it. I designed on the screen, and then this is the final result of the abutment. Also, you can get the data from after you making the CAD-CAM abutment. You can make a model, so you can make a final illustration on top of this model. Okay, I'll show you the clinical case. The 60 years old male, Korean male, came to my clinic with single tooth missing, and I examined the CT scan and I placed the implant. And this is how it looks like after replacement. And I realized 3 months later the implant placed 2 palatally and 2 distally. I don't agree with people who tell us you have to use the customized abutment. Some cases fine with the prefabricated abutment, but some cases may be unique because of location and angulation of the implant. So this case was kind of that. So this is how it looks like after impression copying connected. And this is how I made the impression. So this is my clinic. I have 4 chairs in row. And this is, I recorded and encoded 3 times faster because of the time limitation. So this is how it's working. So I took upper already, and lower I'm taking antagonist. So inside, so this is actually taking bite. So only few pictures on the bite can give you a occlusal registration, bite registration. After a few seconds, you can see the virtual model on the screen right next to it. So it's very easy and precise to check how impression is good. And also, for the impression, the implant cases, you don't need to worry too much because of the margin. Detection is not critical. So after that, I used the data and I designed the abutment. When you see this, I told you that I placed the implant 2 palatally and 2 distally. So this is how emergence profile comes with. So I extended to the other side a little bit, but I was considering about the tissue response. I don't want to put too much. So I control. I control the distance from the center, and I ask the company to fabricate the abutment that I designed. This is how it looks like after fabrication and final restoration. Then in the mouth. And I tried it in the patient mouth. So I haven't changed. I haven't used any impression material for this patient, and we only use the data and the model that fabricated from CAD/CAM were used. So when you think about making customized CAD/CAM abutment, we have two ways to do it. So one is the workflow that I showed you before, and this is the way we used to do it. An implant level impression, making model, and the model scan with scan body or pin, and then we can design and fabricate the model and the abutment. So I was thinking about, can we use this digital impression in different ways? So I was come up with the one-step implant treatment, which I'm calling. There's a modification. So you use an impression, digital impression, not at the time of making restoration, at the time of surgery, like a surgical indexing. So, like we used to use it for the making customized killing abutment or temporary restoration. So this is a single implant case. Patient come up with a cracked tooth, number 47, and I was a surgeon, but I couldn't take it out right away. I spent a lot of time, and the tooth was squeezed out, and I spent more than an hour to take it out. And then I waited for 2 months, and I placed the implant. You still can see the defects around the previous socket. And after I just placed the implant before bone graft, I connected the scan body, and then I scanned it, and I finished the graft and connected to the healing abutment. This is how it looks like right after the placement. Okay, and made the data, designed the abutment. Tissue looks like too big because this is the pictures before I closed the flap. So this looks like very thick, but I checked the margin. So this is right after fabrication of abutment and crown. And 3 months later, I tried it in patient mouth and cement. So you can see the tissue impinging a little bit, and by the time it's improved, and I finished the case. So this case, when I made the impression, digital indexing and the surgical indexing at the time of implant placement. 3 months later, without any procedure, I could just finish the treatment. Because during the 3 months, I could make a final restoration and customize abutment using the data. So this is the conclusion I come up with. Digital impression can be used for both implant level and abutment level impression. Digital silicon indexing is also possible and has many advantages. Prefabricated abutment cannot be used from digital impression level impression. This is only disadvantage that I'm thinking, and we need more clinical trial for evidence. Thank you very much.
Thank you. Do you have any question?
Okay, that's a very good question. Let me repeat the question. And he asked me what kind of implant system you can make with digital impression by the ICOI. Yes, that's a very good question. I don't know many of you noticed or not. I place single implant with external hex. Usually we don't place external for single one, right? Usually I love to place internal connection for the single implant, especially posterior. But I had to use the external connection implant that has an external connection because all the external connection, 2.7 millimeter external hex can comparable to the other company. So that's why I placed the external. And the one domestic, a Korean domestic company called Dio has this system. So they have, if you place the depth implant with the internal connection, you can still make the digital impression. Again, and all the external hex implant, like a traditional one, you can make digital impression. And also in the Europe, the Cadent iTero is distributed by the Straumann. So maybe, I don't know about the Straumann, but they may have this kind of option too in Europe, not in Korea.
So your comments on your digital impression today is because you cannot use a prefabricated part.
Right.
What other limitation do you have?
What other digital impression? I don't think about too much about the complication or limitation in digital impression because if you can just open the mouth, you can still think. But not for the implant case, most disadvantage of using digital impression is a deflection. So you have to have a moisture control very well. And if you have too much bleeding, you cannot take the pictures because this is not taking pictures of tooth or implant. This is taking pictures of external surface. So if you have a contaminated surface, this digital impression will not work. So you have to have a clean wound, and you have better have less reflection, like the metal restoration or amalgam filling, whatever comes with the metal.
The challenge is because the digital impression in the US has been talked about it, but it's not widely used. And the concern is the accuracy of the digital impression.
Yeah.
I know from your study you show there's no difference between the conventional. But did you actually look into if you do a metal core versus without metal core, how accurate they are?
Yes, we do have more reflection on the metal core, that I agree. But some systems are using the powder that may prevent the reflection. But this iTero system not suggest to use the powder because it has confocal laser, wet laser technology. So looks like a laser works better than LED, my thinking. And I'm not only the one who come up with this kind of laser on the natural dentition. And several facilities in Korea are competing with the digital impression now. But all their results are almost same, like me. And I recently with the 3M Lava's data, and they even jeopardize that. They are thinking the 3M Lava COS is better than conventional lower impression. I don't know, I can't agree with it.
Thanks very much. We're going to conclude this segment because our next speaker was not here. Am I correct? Okay, so we're going to take a break for 15 minutes. We start at 5 p.m.